case presentation, and if there's time, we'll talk about the literature review. So for the case presentation, baby Sepsis, a male, was brought from labor to the NB on account of hyperpyrexia of 38.1 and loss of life of 13 hours prior to delivery. So this is the hair ticket of the baby. So the baby was born on 10th of February 2022 at 9:51 a.m. With Abgar 7 and 8. EG was 40 weeks plus 3 days. And then the baby was brought, as I said earlier, on account of high body temperature of 38.1 and PROM of 13 hours, loss of life of 13 hours prior to delivery. Okay. So for the maternal history, mother expired 3 to both alive plus 0, regular attendance of A&T. Booking was done at 9 weeks plus 1 day. She had 8 visits in total. For the investigations done, every parameter, all the investigations were normal, For the gynae history, Menarche was 16 years, had a regular monthly cycle. For the drug history, she took her routine A&T medications, but she took all herbal medications on account of painful degenerative fibroids. And for the social history, she's married, a trader, and the husband is a cleaner. So with the obstetric history for that particular pregnancy, the one we are talking about, she had 5 admissions in total. 4 were on account of painful degenerative fibroids, where she was admitted for about 5 days, maximum for about 5 days, and pain medications were given and discharged. And the last one was on account of UTI, where she was admitted for 72 hours and given antibiotics and discharged. Aside these 5 admissions, she didn't have any other hospital admission during this pregnancy. So as I said, EGA 40 weeks plus 3 days, was delivered via SVD cephalic presentation. There was a perineal tear which was repaired. Abgars were 7 and 8 in the 1st and 5th minute respectively. Birth weight was 3.2. So on direct question, the child cried at birth. There was no seizure, there was no grunting, no fast breathing, there was no vomiting or resuscitation done. So the baby, who was an hour old then, was admitted at NB on account of neonatal sepsis. With initial examination done on admission, for general, the baby was pink all over, was active, was anecteric, but very warm to touch. There was normal breathing pattern, there was no chest recessions, no endurance. The cord was intact, not bleeding nor discharging. So the vitals, when the baby was admitted, temperature was 38.1, respiratory rate 60 cycles per minute, heart rate 156 beats per minute, SpO2 was 95%, RBS 4.7, head circumference 34 centimeters, female length 54 centimeters with a weight of 3.460 kg and RDS of 1. So the RDS was 1 because respiratory rate was 60 cycles per minute. There was no grunting, there was no recessions, entry was good, and the child was not on oxygen. So these are the initial vitals, as I already mentioned earlier, and then these vitals were recorded later during the day. Okay. So for respiratory rate was 60 cycles per minute, entry was adequate bilaterally, vesicular with no added sounds. For cardiovascular, capillary fill time was less than 2 seconds. Heart rate was 156 beats per minute. Heart sounds 1 and 2 were present and normal. For the CNS, primitive reflexes such as the Moro, grabs, and routine were all present and normal. Abdomen was full, soft, non-tender with no organs palpable. So a diagnosis of early onset neonatal sepsis was made with potential differential diagnosis of urinary tract infections and congenital pneumonia. So with our management, we requested for full blood count and blood culture. And then we gave antibiotics, cefuroxime, 50 milligram per day weight for 5 days. 8 hourly, and then gentamicin 4 milligram daily per the weight, also for 5 days. And we gave 10% dextrose, that was 50 millimils per the weight in 24 hours. And then we monitored the temperature, SpO2, heart rate, and RBF 2 hourly. So for the FBC results, WBC was 7.7, HB was 13.7, MCV 93.3, platelets 275. Everything was essentially normal except the neutrophil percentage, which was 43. And using the reference range given, 43 was low. So on day 2 of admission, the child was pink all over, was anecteric, not in any obvious respiratory distress. The child was warm to touch with a temperature of 37.1. For respiratory, chest was clinically clear. Heart rate was 133 with heart sounds 1 and 2 being normal. CNS was alert. The child was alert with normal reflexes. So the vitals, temperature is 7.1, heart rate 133 beats per minute, SpO2 98. We got an RDS of 1 because the respiratory rate was 68 cycles per minute. So for day 2, the issue was the mother wasn't getting enough breast milk for the baby. So we switched the 10% dextrose to 10% dextrose in 1/5 normal saline. We continued the ceftriaxone gentamicin, and we encouraged the mother to put the baby to breast. And on day 3, for the general assessment done, the child was seen to have scleral jaundice. Other signs were unremarkable. Systemic review was normal. With the vitals, temperature was 36.2, respiratory rate 59 cycles per minute, SpO2 97, and an RDS of 0. But the highest temperature recorded during that day, that's day 3, was 38. And we realized the baby was wrapped. So we unwrapped and we rechecked the temperature, and it was 37 degrees Celsius. So on day 3, the same day, we took samples for SBL, for the scleral jaundice. And the results were as follows. Total bilirubin was 196.8, direct was 11.5, and then indirect was 183. Plotted, sorry, the next slide. Plotted, you realize that the child was 10, so we are using this curve, and then 196.8 is somewhere here beneath this line. So it was below phototherapy, and the child was 48 hours then, so they're using this, and it was below phototherapy. So the plan was to continue IV fluids, continue antibiotics. The mother was encouraged to breastfeed child and then monitor the vitals 4 hourly. So from day 4 to 5, the child was doing clinically well. The vitals, temperature 36.2, respiratory rate 44 cycles per minute, SpO2 was 98% on room air. Mother was getting enough breast milk for the baby, so the plan was to stop the IV fluids, continue breastfeeding, continue antibiotics, and monitor the vitals 4 hourly. On day 6, the child had completed antibiotics for 5 days. There was no complaints from the mother. On examination, the child was pink all over, still had scleral jaundice, but it was resolving. The child was not in any obvious respiratory distress. Respiratory rate was 45 cycles per minute. The chest was clinically clear. For CVS, heart rate was 136 beats per minute. Heart sounds 1 and 2 were present and normal. CNS, the child was alert with normal reflexes. Vitals, temperature 36.2, respiratory rate 45 cycles per minute, heart rate 163 beats per minute, SpO2 was 97 on room air, and RDS was 0. So the temperature has settled for more than 48 hours, and then the mother was lactating well. So the plan was to discharge the mother, but then counsel the mother first on hand and environmental hygiene. And then the mother was encouraged to do exclusive breastfeeding and breastfeed frequently, and to discharge and review on 22nd of February. So this is a graph of some vitals the LEM system here could capture for us. That's the temperature and the respiratory rate. So you realize, as I said earlier, the temperature went as high as 38 on day 3 or day 12 live, but we unwrapped and then it came down to 37. But we realized we had some spikes too, but it never went above 38. And then with that too, when a child spikes, the temperature still settles. So we monitored and continued the antibiotics. And then we realized here too, for the last 48 hours or last 2 days, the temperatures had settled and they never rose. So yes, we continued the antibiotics. So the problems were, for the respiratory rate too, initially it was on 62 cycles per minute, and then it rose to 68 cycles per minute. But then later on during the day, and then as the days go by, it dropped. So the problems we faced were that we requested for FVC and then blood culture, but the blood culture could not be done due to financial constraints. And also we realized the baby was delivered with high body temperature, 38.1, but the mother had no form of investigation done to find the cause of that. Example, sepsis screening. Yes, so that's it for the case presentation. So I'll move on to the literature review. So for the literature review, I talk about the introduction, the definition, etiology, pathophysiology, the signs and symptoms, investigations, differential diagnosis, complications, and treatment. So what is neonatal sepsis? It refers to an infection involving the bloodstream in newborn infants. It remains a leading cause of death amongst neonates, especially in the middle and lower income countries. It's the most expensive inpatient cost in America and even some parts of developing countries. 27 to 30 million children were diagnosed with sepsis. 30% of them had severe sepsis and did not survive. Sepsis affects all in terms of sex, age, and race. It affects more males than females and preterm than term, sorry. With the males, it's seen that they have less CD3 and CD4 count cells, as well as low immunologic response. That's why they are risks of neonatal sepsis as compared to females. So in 2012, it was estimated that approximately 680,000 neonatal deaths occurred in developing countries were due to bacterial infection. A study conducted at NICU, Akolebu, between 2017 and 2018 stated that 2,400 neonates were diagnosed and admitted on account of neonatal sepsis. So it's defined as clinical syndrome of bacteremia with systemic signs and symptoms of infection in the first 4 weeks of life. It may be categorized as early or late onset neonatal sepsis. Early onset occurs within the first 72 hours and late onset after 72 hours. 85% of newborns with early onset sepsis present within 24 hours of life, and then 5% within 24 to 48 hours, and about 1% within 48 to 72 hours of life. So for early onset neonatal sepsis, the microorganisms most commonly associated with would be Streptococcus, E. coli, Coagulase negative Staphylococcus, Haemophilus influenza, and then Listeria monocytogenes. The risk factors associated with early onset neonatal sepsis include maternal B. Streptococcus colonization, mostly from the skin to the bloodstream, premature rupture of membranes for more than 24 hours, preterm delivery and low birth weight, meconium stain liquor, choamonitis, and maternal urinary tract infections, maternal fever or leukocytosis. And for late onset neonatal sepsis, as I said earlier, for late onset neonatal sepsis, it's acquired from the environment or the hospital. The organisms most commonly associated are Coagulase negative Staphylococcus, Staphylococcus aureus, Pseudomonas, E. coli, Klebsiella, Enterobacter, Candida, group B Streptococcus, and anaerobes. So the risk factors are urinary and IV catheterization, central venous catheterization of more than 10 days, it could be less, chronic mechanical ventilation, or nasal cannula or CPAP, and exposure to antibiotics, which select the resistant bacterial strains. So neonates with early onset normally present with pneumonia, and those with late onset present with meningitis, it could be meningitis, bacteremia, osteomyelitis, or arthritis. So with the pathophysiology, we know gram-negative bacteria produce endotoxins when they are cell wall lice, and then gram-positive produce exotoxins. So with the gram-negative, when the cell wall lyses and then they produce endotoxins, it binds to lipopolysaccharide binding protein, and this then binds to macrophages using the CD14 receptor. When this happens, they release some cytokines and mediators such as tumor necrosis factor, interleukins, interferons, and platelet activating factor. Now, when this happens, other parts of the body produce a response. So one is the brain. In the brain, the hypothalamus stimulates COX to produce prostaglandins, and then this causes fever. And with the fever, the physiological response you could see associated with that could be tachycardia and tachypnea. And also with the capillary endothelial cell wall, there's normally extravasation of fluids to the tissues, extravasation of some cells to like neutrophils, and then they they migrate to these tissues, and when this happens, they cause an inflammatory response. And with the inflammatory response, there could be consumption of clotting factors, which could cause DIC and could be seen as thrombosis or hemorrhage, and also depletion of intravascular volume. Also with the vessel cell wall, there's synthesis of nitric oxides on the cell muscular wall. This causes vasodilation, and then the vasodilation decreases mean arterial blood pressure, and this causes decrease or poor perfusion to the tissues, and therefore cellular hypoxia, and then low systemic vascular resistance, and then therefore lactic acidosis, and then tissue death. Okay. So with the signs and symptoms associated with neonatal sepsis, for general, we have temperature instability, could be hypothermia or hyperthermia. There's poor feeding, there's mottling, which is web-like appearance on the skin due to infection, or patches on the skin, seen on the skin. There could be lethargy, jaundice, decreased movement of the extremities. The cardiovascular system, there's bradycardia, there could be tachycardia, capillary flow of more than 2 seconds, and then shock. With respiratory, there's apnea or gasping, there's respiratory distress, there's chest retraction, cyanosis, grunting. Central nervous system, it could be hypotonia, that's decreased movement of the extremities, irritability, seizures, high-pitched crying, and bulging fontanelle. For gastrointestinal tract, we have diarrhea, vomiting, and abdominal distension. Hematology, there's jaundice, pallor, petechiae, and bleeding diathesis. And for renal, there's oliguria, and then fluid overload from AKI or kidney failure. So for the investigations, we have specific, non-specific, and radiologic. So for the specific, we have blood culture, which is the gold standard. We could do CSF, biochemistry, and culture if the child has neurological signs. We could do urine culture, after 24 hours, mostly, if the child has urinary symptoms too. For non-specific, we have WBC differential counts. We have C-reactive proteins, which normally rises after 12 to 24 hours when there's an ongoing infection. We could do arterial blood gases. We could tell us if there's metabolic acidosis, there's hypoxia, and also procalcitonin, which is seen in monocytes. And so when there's an infection, procalcitonin rises, and also electrolytes. For radiology too, we could do chest X-ray because they might present with the respiratory signs. So we have to find the actual cause of the respiratory sign and symptom. So differential diagnosis, we have congenital pneumonia, meconium or blood aspiration, metabolic diseases causing hypothermia or hypoglycemia, respiratory distress syndrome, pulmonary air leaks, example, pneumothorax, interstitial emphysema, and pneumopericardium. Could also have necrotizing enterocolitis, and also transient tachypnea of the newborn. So complications, using the picture I explained earlier, we could get septic shock and then also anemia, especially when there's associated kidney failure. Even without the kidney failure, we could get anemia. We know that the kidneys produce erythropoietin. So when there's kidney failure, we could get anemia. Also DIC on account of consumption of the clotting factors causing excessive hemorrhage. Also end on organ damage due to the tissue lactate producing and then causing death of the tissues. There could be permanent lung damage from acute respiratory distress syndrome. There could be permanent brain damage from meningitis. Also damage to the heart valve, which would cause heart failure and also septic embolism. So for the treatment, we have first line, second and third line. For the first line, when there's septicemia pneumonia or pneumonia, you would give ampicillin and gentamicin. And then you give meningitis when you give cefotaxime when there's meningitis, sorry. Second line, ampicillin or clozacillin and gentamicin for septicemia or pneumonia. And then for meningitis, you add cefotaxime. For third line, ciprofloxacin or cefotaxime and amikacin. And then you give cefotaxime when there's meningitis. So you switch to appropriate antibiotic when culture result is ready and when the child is not clinically improving with initial therapy. But we realized we gave cefotaxime and gentamicin to our child because research done in Ashanti region stated that the neonates were resistant to ampicillin, but rather sensitive to cefotaxime. So in Ashanti region, mostly we do cefotaxime and then gentamicin. So supportive treatment for respiratory, we give oxygen and ventilation as necessary. For cardiovascular, you support blood pressure with volume expanders. Hematologic, we treat DIC with fresh frozen plasma. For CNS, we treat seizures with phenobarbital. Metabolic, you correct hyperglycemia and then metabolic acidosis, sorry. And then you encourage breastfeeding. Thank you. These are my references.
Can you please stop sharing your screen? Thank you.
Yes, please.
Okay, so thank you very much, Vera. Okay, please, are there any questions?
Yes, I do have, please, one question. Can you please repeat what you have just said about what do you know about the antibiotic resistance in the Ashanti region? Can you just repeat that sentence? It's a very important sentence that I want to understand.
Okay, so we all know that first-line antibiotic use is ampicillin and genta. But some years ago, Confanochi was not having very good results with the use of ampicillin and gentamicin as first-line treatment for babies that came in with sepsis. So they undertook a study, and then at that point in time, we had ampicillin resistance. So it was a general consensus at that time to switch to cefuroxime genta, and that is why for us, most of the facilities in Ashanti region, we tend to use cefuroxime and genta as our first line. What I must add, however, is that there have not been any other studies since then, and it's been years So I can't tell what the resistance is now. That study was actually led by Confanoche. So by practice, that is what we all use, Cefroxime Genta as our first line instead of ampicillin Genta. Thank you.
Okay, and the second question was the baby at the beginning when she had the fever, was she on an overhead heater or where was the baby managed?
So the baby was managed at the labor ward, please. The first fever, the baby was from the labor ward. And per our protocol, when a baby at the labor ward or lying in has a fever, the first thing they do is to expose the baby, remove excess clothing, and then recheck the temperature in the next 15 minutes. If the temperature has gone down, then we know that it's actually due to the excess clothing. But this was checked. So before they bring the baby to the MBU, they would have checked twice before they bring the baby to us. And when they bring, we also check to make sure that it's not maybe the baby is not warm on account of over wrapping or something like that. But there's no radiant trauma in the lying-in ward where the baby was. I don't know whether I make myself clear.
Yes, it's clear. But after that, in the MBU, the baby had fever the next day also, 38.1. Was that on the overhead heater or was the baby in a cot?
Yeah, the three, in fact, I can't remember, but it is very unlikely. I can't remember. It's very unlikely because when they come, usually with sepsis and the baby doesn't need oxygen or any other thing, we nurse them in the cots by the walls, and not under a radiant warmer. It's the fresh ones we receive from labor ward, straight from labor ward, maybe prematurity, birth accident. They are the ones we nurse directly under the radiant warmer. That has been the general practice, but I can't tell whether on the...
Probably this baby having an IV on the first day.
Sorry?
You said that the baby did not have, the mom didn't have enough breast milk, so the baby was given IV fluids. So this would mean that probably he was on the overhead at that day, right?
It could, there's a possibility, but the fact that you are on IV fluids doesn't mean that you be under the overhead.
Okay.
Because
so,
he came to us after 1 hour. It's not like fresh from delivery.
Okay, so any comments? I will have later some comments, but any comments from, any questions or comments from the staff?
Wait, Rita, can you mute? Thank you. Aggie, you want to talk about this case now, or we talk about it later? What are our options?
Well, I think we need to talk about it a little bit now. The session on sepsis actually is planned for the next week meeting. We have a whole session on sepsis, but I think we want a few comments on this case and then proceed with the other two topics which are not related to sepsis.
Okay, so first, Vera, it was really, it's nice presentation of the baby itself and the whole subject of sepsis. We will talk about it later, as Aggie said, but it was very nicely presented. Now, having learned what you learned in the review that you did, is there anything else that you would look in this baby? Is there something missing in the presentation? Is there something that you would say, okay, what is that you question the diagnosis itself of sepsis? how is it possible that this baby didn't have sepsis but had something else? What do you think?
Yes, so yes, it could be possible it's non-neonatal sepsis. That's why I had other differential diagnosis, like urinary tract infection, and then congenital pneumonia. It could be also metabolic diseases, but it was rare. So my first two potential diagnoses were urinary tract infection and then congenital pneumonia. Yeah.
Okay, which is practically for a baby, it's the same. I mean, congenital pneumonia or urinary tract infection, which is also very rare at 1 hour of age, they are the same. That they are considered as sepsis for a baby like this. Okay, but you in your presentation you said that there are several risk factors for sepsis. Did this baby had any risk factors for sepsis?
So we had, there was loss of liquor. Initially they made it prompt, but because it was just 13 hours, I just made a loss of liquor, which could be a risk factor. And also the mother was admitted during pregnancy on account of UTI. One, the UTI itself can cause the neonatal sepsis, and also the hospital admissions she had 5 of them. With that to the whatever went on during the admission, be it the IV canalization and what, we don't really know what went on, but also the hospital admission itself could cause neonatal sepsis. So, yes.
Okay, but this is not a risk factor, because if mother deliver in the hospital, it's not a risk factor. But from the risk factor that you said, I don't know when the urinary tract infection of this mother was, but did the mother had fever? I don't remember that you told us if the mother had fever.
So the mother presented to the hospital with fever and then abdominal pains, lower abdominal pains. So I just made it brief that a diagnosis of UTI was made during the pregnancy. She was admitted for 72 hours and given antibiotics and then discharged.
Okay, but the fever itself, was it around the delivery, or the UTI was several days before the delivery?
It was days before the delivery.
Okay.
It was with the admission on account of painful degenerative fibroids that were close to the delivery.
Okay. So when you ask yourself, it's very difficult to have a diagnosis of neonatal sepsis when you cannot get cultures. And in your presentation, you rightly pointed that a definitive diagnosis of sepsis is when you have cultures. And I understand that families have to pay for cultures, therefore it's not, you don't get it easily, and then you have to treat for 5 days because it's difficult to make a definite diagnosis. The other question I had is, you said that the mother didn't have enough breast milk.
Yes.
Did you have the weight of this baby every day? Could you follow the weight to see if the baby is losing weight?
Yes, please, we did. And then I can just, sorry. So,
as Vera is looking at the notes, I just want to bring something up. You know, because of the difficulty we have in making a diagnosis of neonatal sepsis, the curriculum that generally now the Ghana Health Service ask us to use to teach our nurses is the essential care for every baby. So now they ask us to focus on the 7 danger signs, which includes a temperature of 37.5 and above. That's a general teaching now from the Ghana Health Service. A temperature of 37 degrees and above, low temperature, convulsions and all that. and use it as a proxy for diagnosing neonatal sepsis. So it's sort of what is done. In Kumasi South, that is what is done, and I'm sure in Suntreso it's about the same thing. And that is what we have been made to teach our nurses all over the Ashanti region as a national guideline. So I think that is what is happening. So sometimes it's difficult also for us because it's just maybe one fever, you take off the cloth, the temperature is still there, and we are really stuck because of diagnostic issues that we cannot do blood cultures, we cannot do CRP, and even sometimes just a full blood count becomes an issue. So that is it. That is where we are now as a country. So that just
we are very much aware of this problem, but this is also why I'm raising it, because from what you're saying, it's clear that you also question yourself every time if a baby like this really has sepsis or not.
Oh, definitely.
I know that you have your protocols about antibiotics and which antibiotics to give, and we're not going to go into it because it's a protocol in all the area, but you will have sometimes to check out if it is possible to get some blood cultures, even as a research project, in order to be sure that if you are giving the right antibiotics. But the last issue that I wanted, and I wrote to myself, is the issue of jaundice and phototherapy. When Vera, when you showed us the graphs, and you saw that the baby was falling, that his jaundice was below the upper graph, right?
Yes.
You have to remember that if a baby is at risk, you use the middle graph, and this is the threshold for phototherapy. Now, a baby in sepsis is considered to be a baby with a risk factor. Now again, this baby felt very well, and maybe the diagnosis of sepsis was questionable, but you have to remember that this graph, they have 3 lines in the graph. And the moment you think that the baby is at risk, you want to treat you don't use the upper graph, but you use the middle graph.
Okay.
Okay, I want to thank you, Vera, so much for your clear presentation. It gives us a lot of issues to think about. I really wanted to give an emphasis on the importance of differentiating between early onset and late onset sepsis. And early onset sepsis, we look for risk factors from mom. Late onset sepsis is something environmental, something that happens after the baby is born, and some kind of root that is infection, as you presented very nicely in your review. Now, fever in the early onset sepsis is not a very, it's not really, usually it's not the sign of the sepsis. It's usually environmental, or mom was too hot, or the baby was on the overhead heater or something. Other signs such as unwell, clinically the baby is apathic, is not sucking well, the perfusion is poor, it's tachypneic. These are signs of early onset clinical sepsis, right? And there is literature about decision-making algorithms on clinical signs without labs in the developing countries, where it's a problem not only in Kumasi, it's a problem in the developing countries. And then some kind of algorithm that a department is deciding that this is what we do. We need to have at least 2 clinical signs of a certain category in order to start antibiotics. And the problem is, of course, as you are aware, that we do not want to abuse antibiotics, because then we have all the resistance developing, and then you don't have any more antibiotic left for severe infections. And really, without, like, this baby was clinically well. The baby had leukocyte count was okay, a little bit shift to the left. And maybe risk factors were debatable, I would say. You can really make a list of risk factors, maternal risk factors and infant risk factors, and then really decide very carefully in each case whether you need antibiotics. So I will send to Rita, and Vera, you will have the access to this literature that I've recently read about clinical signs used in decision-making for treating, to use antibiotics. And the second thing is, Rita, that's absolutely necessary that you decide what is the etiologic factor most prevalent in your hospitals, and then use the antibiotics that is recommended by the WHO, which is ampicillin and gentamicin, and not the third generation cephalosporins. So Confanoce is Confanoce. Now, if you can have some kind of surveillance and decide what are the bacteria in your setup, would be saving a lot of money after that. You do not use antibiotics, which are expensive and danger to develop resistance. So I think in our setup also, we once in a while look at what are the etiologic factors, and we choose the empiric antibiotics based on the most common bacteria that are causing the early onset and the late onset sepsis in your setup. So I think we'll have more discussion next meeting about the sepsis. I will send you a few articles which I have now regarding the sepsis in middle and lower income countries. Miki, do you have any comment?
No, I have no comments.
Okay. Anybody else? Any more questions or comments? I think Benil will be able to, if you send him a question about what what is the percentage of babies in your units that receive antibiotics, it's very, very, very high. So the question is, how can we improve our decision making in deciding which babies need antibiotics, and which antibiotics and for how long? It's very important, especially that if the resistant antibiotic will develop, then we are in big trouble. Elon, you have last word?
No, first, again, as I said, it was a very clear presentation. And I think that there are issues, of course, that we're not going to solve, because it's a kind of policy all around in Ashanti region. We do know that using cephalosporins is not, it increases the, how do you say, the resistance of bacteria. But I think this is a policy that has to be re-looked at all over Ashanti region. It's not possible to do it in one hospital, though it would have been nice if we could do it. Am I right, Rita?
Yes, you are. Ashura, Dr. Benin, you are all here. I mean, Please share your thoughts.
Hi, this is Joyce. So for my fellowship topic, I'm actually thinking on working on this. My issue is I'm trying to raise some sponsorship because blood cultures are expensive to do. I may not be totally able to fund from my pocket, so I'm looking at getting some sponsorship at least to aid some part of the cost, to bear some part of the cost. So maybe that will help.
That's great, Joyce. If you have a research protocol written, which is very clear with a research question and the need to find answers to this question, we can help in reading and making sure that, or to think together how we can proceed with this important work. How can we find funds? How much fund is needed? And so on. So it's a big issue, of course, but it has to be done.
Yes, thank you. So I'll continue the work. I have to finalize my sample size with one of our bosses at CAT. So once I'm done with that, I'll send to you. Thank you.
You're welcome.
And also, sometimes it's possible to get grants, even maybe, from your own Ministry of Health, because eventually it will, if you will be able to use only gentamicin and ampicillin, because you will show that the bacteria are not resistant, it will save some money to the hospital. So it's, but you should look if there are available grants. If you have a good project and you're able to, and you know how much money you will need for it, you should apply for a local grant even. It's not a big work what you're trying to do.
Yes, so I'm looking at all the options. I have a meeting scheduled with someone during the week, so I'm trying to explore all options. Thank you.
The other last comment that I would have is, I'm sure, Rita and Ashura, that you do have antibiotic protocol in the unit. If this protocol can be looked at again and maybe emphasize the risk factors and in the decision-making algorithm that can help and can be consistent about starting the antibiotics. So it's not enough saying that 37.5, maybe it's enough if this is a criteria, but maybe putting together a few criterias and being like an algorithm kind of thing on the starting antibiotics. So I think this is a topic that we will have to discuss again and again. Maybe we'll widen the discussion after next week presentation by Winty. And then we see what we can do. So thank you so much. I think that if anybody has any, Vera, good job. Thank you for bringing us this very, very important topic. It's a hot topic in neonatology in our MBUs, really hot topic.
So someone has a question in the chat, so I'm wondering whether we should save it for when Wendy has finished the presentation, then we try to answer
the question. Let's see if it's what happens when a baby is 5.
Okay. Okay, she says, what happens when the baby spikes temperature continually without any clinical symptoms of sepsis? Lab investigations also review no infections. What should be done for this baby? So probably that was what I was thinking. When Wenty is done, the picture opens up and we have a fruitful discussion on that.
Okay, just a comment on this, that you have to remember that if the baby is not feeding enough or is not getting enough fluids, they may spike their temperature, and it should be checked. I mean, the weight of the baby should be checked. You have to see if he's getting enough food. Sometimes you can add up food instead of giving IV fluids. You can give fluids orally or by NG tube. It might be even better than to give them IV, because by giving IV, you can also cause sepsis. But each case, every baby should be checked again and again. And of course, there are some very rare diseases that cause spiking fever, but it is very rare, and I don't think that it's difficult to diagnose them.
And again, remember early onset versus late onset sepsis. It's two probably very different issues that need to be sought separately. And the physical examination is most important part. A septic baby looks ill. He looks ill. He doesn't feed well. It's apathic. The perfusion is not good. And only fever alone gives us some time to look at the baby and do not start antibiotic only because of the fever. If all the rest is normal, like a good-looking baby, vigorous, sucking well, and it's a very reassuring sign that we are allowed to wait and see the baby.